If anyone can please just, if anyone interested, help me out with reading the questions.
I can start. Number one, a 40-year-old healthy male has a heart rate of 72 beats per minute. His end systolic volume is 80 mils and his end systolic volume is 170 mils. What is the cardiac output in 1 minute? So the difference is 70 is being ejected per beat. So 72 times 70 is about 5 litres. So answer A.
Yeah, so cardiac output is the stroke volume times the heart rate, right? His heart rate is 72. Is that right? His stroke volume, his stroke volume is basically
150 minus 80 is 70.
Yeah, so 70, is that right? 70 ml. So it's about 5 liters. That's correct. So it is about 5 liters. What kind of factors that affect the cardiac output? What do you think? Can you name factors related to or alters the cardiac output?
Yeah. Just quick question. I thought we started at the beginning. This is May 24. How come we're back to question 1? Because we did a session the other day.
No, I said maybe you missed what I said at the beginning of the session. I said that there is a technical problem with file. The team is working on sorting that out. And until then, we will just discuss another exam.
Oh, I see.
Doing another exam. So, yeah, what do you think, Dr. OIS? I said that, can you name, just in brief, like the factors that are affecting cardiac output?
Oh, right. Cardiac output is stroke volume, heart rate. Can't think of anything else.
So you should also think about like the things that would affect the stroke volume, like myocardial oxygen supply, initial fiber length, the preload, which is basically the same as saying initial fiber length, etc. The inotropy of the heart, the state of the valves, right? Whether or not there's any outflow obstruction, and those things. So you know that when patient is shocked, what do you do when patient have hypovolemic shock? You will give him fluid challenge. Is that right?
Yeah.
Yeah. So according to the CREST protocol, 10 milliliter per kg if patient is normal tensive.
Yeah.
So 10 ml per kg if patient is in shock. Of course, patient in shock can be normal tensive, right? Normal tensive.
Yeah.
And 12 milliliter per kg if the patient is hypotensive. Okay. The ATLS principle, last edition of ATLS, they say give 1 liter of crystalloid solution as a challenge without mentioning per weight. But in CREST protocol, they mention weight. So basically, you are giving large volume of fluid rapidly. So basically, you're giving it rapidly. Why would you want to give it rapidly? Why not just increase the drip, for example?
I think you want to see if it makes the improvement. So you want to give it as a bolus so that you can see if it solves the problem.
Excellent. So that's one reason. One reason is that for diagnostic purpose, right? When you give rapid fluid bolus, you can rapidly assess the response, meaning that you can categorize patients into 3 groups based on their response to the initial fluid bolus. Group number 1 are responders, meaning they show sustained improvement in the hemodynamic parameters, sustained improvement, or transient responder, meaning only a brief period, not sustained, brief period of hemodynamic improvement, or non-responder. responder means it doesn't make a difference when you give them a fluid bolus. It doesn't improve any of their hemodynamic parameters in any significant way. Is that right? What's the benefit of this? The benefit is that these two groups are actively bleeding. Means they have active source of bleeding. Means they likely need either interventional radiology or surgical intervention. That's, of course, something very important that you would want to know. That's one benefit of giving it rapidly as a bolus. Anyone else can give me another reason why we give it as rapid bolus? So one reason, like Dr. O said, for diagnostic purposes, that when you give it as a rapid bolus, you can assess the response. And based on that response, you can put the patient in either one of these categories: responder, transient responder, or non-responder. The next benefit is, you know, Frank-Starling law, that when you give fluid rapidly, you will rapidly increase the preload to the heart. And when the preload to the heart increases rapidly, there is myocardial stretch. Because there is higher stretch on the fibers, the resultant contraction will be stronger. So the stroke volume will be better. So it can improve stroke volume when you give it rapidly compared to when you give it slowly, right? So these are the two benefits, diagnostic and therapeutic benefit. Okay, now let's see the next question.
A newborn is found to have gastroschisis. Normally, the midgut should return to the abdominal cavity at which time of gestation? B, 12 weeks.
Yeah, so 10 to 12 weeks, then the midgut physiologically herniates outside of the abdominal cavity, right? So it returns back at 10 to 12 week. So it herniates physiologically, but then physiologically should return back. If it doesn't return back, the result is omphalocele, right? The result is omphalocele. We've already talked about that. We've already talked about in the previous sessions that gastroschisis, despite of it being, it's a defect in the abdominal wall, right to the right side of the umbilicus. And we said that if you remember, that it has generally better prognosis compared to omphalocele, because omphalocele is associated with chromosomal abnormalities and other congenital abnormalities like congenital heart disease and things like that, whereas gastroschisis is usually not, right? That's what we said. By the way, in patients that have, I just remembered something regarding chromosomal abnormalities, something relevant surgically in our exam. Do you know, anyone knows Lynch syndrome? Anyone aware of Lynch syndrome? Yeah. What is Lynch syndrome?
So it's like an FAP, FAP with polyps.
It is an hereditary non-polyposis colorectal cancer.
And so it's also called hereditary non-polyposis colorectal cancer. So what's the problem with this syndrome? Anyone knows what's the real problem?
It's that the answer is that DNA mismatch repair gene, and I've seen it in a MCQ. They say, "What's the problem with Lynch syndrome?" And it's mismatch repair gene or something.
Excellent. Yeah. So it is a mutation in a group of genes which are responsible for correcting DNA mismatch. What's the meaning of DNA mismatch? Meaning, normally, so if you have a strand, let me just draw a simple diagram here, right? So that's a strand of DNA, okay? And suppose you unwind that strand. Normally, there are base pairs, right? In the DNA molecule, normally, cytosine is paired to guanine, and adenine is paired to thymine. Is that right? That's normal situation. Now, if by chance, for example, thymine is paired to guanine or to cytosine, this is called mismatch. This is called DNA mismatch. This happens every day in our cells, thousands of times, but it is repaired. The group of genes responsible for this repair of this particular DNA defect are called DNA mismatch repair genes. What DNA mismatch repair genes do you know of? Yes. Can you name some of the DNA mismatch repair genes that you know of that can be mutated in Lynch syndrome? For example, you have MLH1, you have MSH2, and you have MSH6, and you have PMS2, I think, or PMS1, not sure. But these are the four most important ones, PMS, right? In Lynch syndrome, which one of those are most commonly mutated? Yes, I'm about to be impressed by someone. So, Lynch syndrome, is it MLH1 or MSH2? Excellent.
MSH2.
Yeah, thank you very much. Thank you so much for that, really. Yeah, that's correct. MSH2 is the most commonly mutated gene in Lynch syndrome, but any of the others also be involved definitely, and it is autosomal dominant. Is that right? Lynch syndrome is autosomal dominant problem. Now, what is the hallmark of Lynch syndrome in immunohistochemical screening techniques? What is the hallmark that is diagnostic of, or very likely in Lynch syndrome, which is now used? Now, in the back, several years back, not long time ago, they relied on Amsterdam criteria for the diagnosis. Amsterdam criteria meaning there are 3 family members at least that are affected with Lynch-related tumor. 2 successive generations have been affected. One of the family members that have been affected while young, less than 50 years, and those tumors are verified pathologically, right? That's the Amsterdam criteria. But now they don't rely so much about Amsterdam criteria. Now they rely about something else, which is new update. This is new update. What's that thing? You have to know that. This is something that you have to know.
It's one of these things that they look in the eye at something, but I don't know if this is the syndrome where it also has an eye retina problem. I may be confused.
Okay, so you are referring to congenital hypertrophy of retinal pigment epithelium, which is seen in half of patients of familial adenomatous polyposis, but it is not seen in Lynch syndrome, not a typical feature of Lynch syndrome. It's one of the extraintestinal manifestations of FAP, and it's very highly predictive of FAP. When present, almost 100% predictive of FAP. But have you ever heard about microsatellite instability? Microsatellite instability. Yes. Microsatellite instability now, which can be detected on immunohistochemical staining by the absence of DNA mismatch proteins, that's a lead towards microsatellite instability. This is very, very characteristic of Lynch syndrome. Yeah. Who would tell me what are microsatellites? What's the meaning of microsatellite instability? Anyone? What is microsatellites? Have you ever watched the TV show? A funny TV show, actually. It's called Paternity Court. Have you watched that? It pops on TikTok and on Facebook a lot of times, or it's just me. Maybe it's just me. Have you watched the show Paternity Court? Okay, so there's a judge, right? And then there are two parents fighting over, they're not sure this kid is theirs or not theirs. They're fighting over that. And then the judge does DNA, right? DNA analysis to see whether this child is belonging to one parent or the other, right? So actually, what do? They measure the microsatellites. They measure microsatellites. That's how they do paternity situation. Microsatellites are just small repeated sequences of DNA. So suppose there's a repeated sequence of TGGCA, for example, TGGCA. And suppose this TGGCA is the star, we'll just call it star. It occurs on particular distances in the DNA, right? So they will detect the spacing between successive microsatellites, and they are able to match that to the child. And they would know if that child is theirs or not theirs, right? This is normal, it's called microsatellites. Now, microsatellite instability is a feature of DNA match repair. What's the meaning of that? Meaning of microsatellite instability simply put is that DNA repair defect, right? The microsatellites in tumor cells will not be the same microsatellites in the other somatic cells. Is that right? This is the meaning of microsatellite instability. They should be identical because that's the same person, right? But when you take tumor cell and look at the microsatellite distribution and compare it with a normal cell, they will not match. This is called microsatellite instability. It is a hallmark of Lynch syndrome. Please don't forget that. I'm stressing so much on this because this is nowadays in the last edition of Bailey, they say that now microsatellite instability is diagnostic, is one of the things that is diagnosis of Lynch, no longer Amsterdam. Right. Let's move to the next question. Okay. Yeah.
A patient presents with a suspected mandibular fracture following a sports injury. He complains of jaw pain and difficulty opening his mouth. Most appropriate initial imaging study to confirm diagnosis. This is an interesting question because I've seen it as A and B in two different sets of recalls, and it's a very controversial question in some places. Now, I think we had here from last time, we had B, OPG as the correct answer, but I've definitely seen it also listed as CT head in some places. So I don't know, Doctor, if you can comment on whether there's much to choose between them.
Okay, so I can understand that there may be controversy in this question. It's definitely controversial, even in practice. OPG is usually the one that we use initially for diagnosis of mandibular fractures. It's the one that is of usual because it is very simple. It can be done quickly. You don't need CT facilities for that or time-consuming process for that. So it is not definitely. It's not as accurate as CT scanning. CT scanning is the gold standard imaging modality for facial fractures, of course. But as initial diagnostic test, even in the Oxford website, they write it clearly that OPG is the initial investigation of choice in patients with suspected mandibular fracture, just to confirm the diagnosis. If you think it's a more complex issue, then CT scanning, bone window 3D reconstruction will be the best, right? But for this particular situation, as they are asking for initial imaging, so you should begin with simple stuff, right? Like OPG. The answer is OPG, and the reference of this answer is Oxford. So I think it's a very dependable stuff, right? Okay, so let's move to the next question.
So all of the following flaps and their corresponding blood supply are correctly paired, except. So this actually came up again in April exam. So this was good. I knew this one because it's B. The lateral forearm flap is not taken from the posterior interosseous artery. It's taken from the radial, I think. So B is the incorrect answer.
Yeah, so by the way, that lat dorsi flap and thoracodorsal artery, what is the situation where flap, latissimus dorsi flap, is most commonly used?
Breast reconstruction, when they're using an implant and they take the muscle from the back.
Very excellent. So breast reconstruction. Not a while back, I was involved in one of these operations, but it was done by a plastic surgeon. I saw the entire thing. It's very fun. But the defect that was left is so big, but he did a split thickness skin graft to cover that defect, and it was a great, very fun to watch thing. It was a very artistic work, really. But definitely, what kind of microbiological test would you want to do in this patient before you do that kind of flap? Is there anything that can come to mind? Yeah. Anyone have an idea about this? You should do MRCS screen, right? MRCS screen, just to make sure. MRSA. I'm not sure if you call it MRSA, but it's called MRSA here, which is methicillin resistant Staphylococcus.
Okay.
Yeah. Anyway, so
MSRI, yeah.
Perfect. So let's see the next one.
A 27-year-old male presents with spinal shock after a high-speed motor vehicle accident. He exhibits flaccid paralysis, areflexia, urinary retention. Above which of the following spinal levels will the patient be at risk for developing autonomic dysreflexia? So I remember the answer to this being A, T6, I think.
Yeah, that's correct. So actually, autonomic dysreflexia, right? It means that it's kind of, do you know when there is a spinal cord injury, and below the level of injury, there are upper motor neuron signs, right? There is hyperreflexia and hypertonia and spastic paralysis or paresis, and over a very long time, there may be disuse atrophy. Is that right? And there's also upgoing Babinski, right? So it is very similar to that thing, that when there is loss of upper motor control over lower motor neurons, there's hyperactivity of the lower motor neurons after the shock stage has elapsed. Similar principles to the autonomic nerves. When they are no longer under control of higher centers, they will fire rapidly. So the patient will usually present with what? In autonomic dysreflexia, they may present with tachycardia and hypertension and para, with flushing above the level of the injury, right? Which can be very dangerous, definitely. This patient can develop dangerous cardiac arrhythmia, they can develop stroke, they can develop multiple complications because of this. Now, the sympathetic flow is thoracolumbar, is that right? Sympathetic outflow from the spinal cord is thoracolumbar outflow, right? It starts at T1 and down to L2. Isn't that right? So the higher the lesion, the more sympathetic neurons will be active and fire, right? So very logical. So it means that lesions that are usually above T6, are going to lead to a lot of trouble with autonomic dysreflexes. You will see in the website both times, right? This explanation. If you want, take a screenshot of that or something, but it's in the website, so you shouldn't find trouble finding it. It says basically, yes, I just wanted to highlight something here, which is a minute, that can be important. Okay. Yes. This thing, bladder or distension, bladder or bowel distension are the most common triggering factors or triggering causes for autonomic dysreflexia. So it means that the simple act of putting the catheter can alleviate this problem. Simple act of putting a catheter can reduce the severity of this problem. So that can be something like in the exam, what is your initial management or what's your initial intervention? Your initial intervention is to detect the triggering factor, like bladder overdistension, bowel overdistension, inadequate pain control. Controlling that will control the problem. Okay? Let's see the next question.
So, a female post-mastectomy patient presents with difficulty raising her arm and a winged scapula. Which of the following is true regarding the origin of the affected nerve responsible for this presentation? So, roots of brachial plexus, cords of brachial plexus, anterior rami of the upper trunk, posterior divisions of the middle trunk, or none of the above. So, I think it's the serratus muscle, right, which is supplied. I'm a bit stuck. I need some help.
Okay, so actually, serratus anterior is supplied by long thoracic nerve, right? You can remember SALT, serratus anterior, long thoracic, right? SALT. The long thoracic nerve originates from where? That's the question, simply. The origin of that, what's that called? The long thoracic nerve of Bell, if you want to call it. Also, some people like this name. Yeah, so Dr. Idris said option A. Yes, it originates from the roots of the brachial plexus, right? C5, C6, and C7 roots. C5, C6, and C7 roots. And then it descends, yes, along the medial wall of the axilla, superficial to the serratus anterior. It's very exposed, so it can be easily injured in this location, right? Okay, so that's definitely option A. Let's see the next question.
So early in embryonic life, which of the following is the first site of hematopoiesis? And the answer is yolk sac. I've seen this question many times. So
Yeah, so
B.
Yes, that's correct. So yolk sac is the first site, and then this is followed by the liver, and then the liver and spleen, and then it moves to the bone marrow in the end, right? In the end, it's going to move to the bone marrow. Anyway, let's look at the next one.
A young, athletic, otherwise healthy patient presents with a single rib fracture. He complains of severe pain. Plain x-ray of the chest is normal apart from a fracture at the left fourth rib. He is hemodynamically stable and there's no other injury. Which of the following is the best course of action? Administer oral analgesia and discharge, admission of observation analgesia, infiltration of wound, chest drain, or none of the above. So A looks reasonable. Give some painkillers and discharge because it's only one rib, right?
Right, that's correct. There's no complications from that. It's just a simple rib fracture, not complicated. And in a patient who's young and healthy, it's reasonable to discharge the patient on simple oral analgesics. Okay. Okay, let's see the next question.
A 75-year-old woman is on T3 thyroid replacement therapy following total thyroidectomy done for an undifferentiated thyroid carcinoma. It is suspected that there is recurrence of the tumor. Which of the following is the most likely lab findings? So TSH normal, T4 normal, T3 normal, and calcitonin normal, and then various options with TSH low and T4 low or raised,
Okay.
T3 raised.
No problem. Yeah, so it's
So
actually.
I don't know where to start with this one.
Yeah, so actually it's like, and when you face a question like that with options, always guys try to answer it before you move to the options, because that's just going to make you lose time and get confused more, right? So Dr. Muhammad Ma'moon in the previous said, what if he has diagnosis, he has some kind of complication, like tension, pulmonary contusion, that leads to respiratory failure if the patient has cyanosis, for example, right? So it means that this patient definitely cannot be discharged. Is that right? So anyway, this patient is on this patient is on T3, unusual replacement therapy. T3 usually we replace with T4. He had total thyroidectomy for something that is undifferentiated. Undifferentiated means anaplastic growth. What is the tumor marker that is commonly seen in anaplastic growth like this one, anaplastic thyroid cancer? Is there any tumor marker that is raised? Yes. My question is there any tumor marker that is increased in undifferentiated thyroid carcinoma? There isn't, right? Undifferentiated, there isn't. It is undifferentiated thyroid cancer. It does not produce thyroglobulin. It does not produce calcitonin. It is the biochemical markers for it are very not reliable. So many people think for some reason, and I don't understand why, they think that undifferentiated thyroid cancers produce thyroglobulin. So they think that if there is recurrence, thyroglobulin should be raised. This is not correct. So let's analyze it logically. First, just know that thyroglobulin will not be raised, even if there's tumor recurrence. So thyroglobulin, we'll write here, thyroglobulin will be not raised, right? That's one thing to keep in mind. Thyroglobulin not raised. Okay, this patient had total thyroidectomy, so that means that their endogenous T3 and T4 production is low, or is absent basically, but he's on T3 replacement. So T3 will be either normal, raised, or reduced, depending on the correction. Is there overcorrection, or there's undercorrection, or it is corrected well? Do you agree with me up to this point? Everyone agrees? Okay. So thyroglobulin will not be raised. T3 may be normal, maybe raised, maybe. Okay, what about T4? T4 should be very low. Because peripherally, T4 can be converted to T3, but not the reverse. That is, T3 cannot become T4, okay? T4 can become T3, but not the reverse. So because you're already T3, right, not T4, and the thyroid gland is no longer there, so it cannot produce T4 definitely. So it means T4 will always be low in this patient. There's no other possibility, okay? Now, thyroglobulin, we say not raised. T3, normal, high or low. T4, definitely low. Calcitonin definitely not in the picture, right? Calcitonin produced by medullary thyroid cancers. So it's not related to undifferentiated thyroid carcinoma. So definitely you can forget about calcitonin stuff, right? So what about TSH? Yes, TSH, what do you think? Anyone can tell me what can be happening with TSH? Yeah.
Hi.
Dr. Ahmed said TSH will be high. Okay,
Yes.
that's okay. All right. Any other idea? Anyone else?
I think it will be low.
It will be low. Okay. Any other possibility? Yeah, so Dr. Rimas said according to the dose, which is correct, yes. If you are giving too much T3, TSH will be suppressed. If you are giving too less of T3, TSH will be raised. Right? So if there's overcorrection, TSH will be depressed. If there's undercorrection, TSH will be high. If the correction is just fine, TSH will be fine, normal. So TSH is also variable, high, low, or normal. So do we agree on these possibilities? With the possibilities that can be present in this patient, we establish that thyroglobulin will not be raised. We establish that T3 can be variable, T will be low. Calcitonin will not be raised, and TSH can be variable. Those are the possibilities. So let's look at the options and see if they fit our possibilities or not. So option A is saying TSH is normal. It's possible. T4 is normal, not possible. So don't continue to read. No need to continue reading. You will waste time. T4 is always low in this case. So option A cannot be. TSH, option B now. TSH is normal. So it is, yes, as we've established. For normal, again, cannot be. So continue reading option B. But the option C. So it can be. Said it. T, it cannot be. So don't continue. Option D, TSH, low. As we said, it can be. T4, low. We said that it can be low. Possibility. Thyroglobulin low. It's a possibility. Calcitonin normal. Option D is fitting with our analysis. Right? Option D is fitting with our analysis. Let's see, option E is saying TSH low, T4 low, T3 normal. Up to this point, it's fitting. But here they said thyroglobulin raised. It's not fitting, right? We said that. We've established that undifferentiated cancers do not produce globulin. That option D is the correct one. Dr. Ahmed said, can you explain again why T4 should be low? Because this patient had removed their thyroid gland, right? They've had underwent total thyroidectomy, and the replacement therapy is T3 and not T4. Now, if you give T4 to this patient, T4 tablets, those can be peripherally deiodinized into T3. It can be, this is possible. But it's not possible for T3, if you give it exogenously, to T4. Not possible, right? So that's why T4 is going to be definitely low or even undetectable. Okay? Are we clear on this funny question? Option D, right? Everyone agrees with me?
Yes.
If anyone have some kind of disagreement, just tell me. Agreed?
So,
So
you said that undifferentiated carcinoma are not anaplastic one?
undifferentiated thyroid cancers are thyroid carcinoma. Differentiated is the same as anaplastic, right?
Yeah.
These tumors do not produce thyroglobulin. They do not use thyroglobulin, do not produce T3 or T4. So even if they recur, there is recurrence. T4 will not be altered, T3 will not be altered, and thyroglobulin will not increase, right? So for example, if they have follicular thyroid carcinoma, or if they had biliary thyroid carcinoma, these are differentiated. These are differentiated thyroid cancers. They may produce thyroglobulin, right? So you can raise in their blood, these patients. But anaplastic growth, by definition, it's anaplastic, meaning it's not resembling the normal thyroid tissue and it doesn't have its functions. So it will not produce thyroglobulin. Is that right? Even when you stain immunohistochemically, if you take a piece of tissue from this tumor and stain it immunohistochemically, it will not be positive for thyroglobulin. So in cellular level, it does not produce thyroglobulin. Is that right?
Yeah.
Did you get your answer, Dr. Muhammad? No problem.
Yeah, I got it. Thank you.
Perfect. Okay. Thank you. So, I hate these questions. Yeah. Go ahead, doctor, if you can, please.
A study was conducted on a new suture material that resulted in a 20% reduction in infection rates. The p-value obtained from the study was less than 0.05. This means the results are statistically significant, suggesting the suture may be effective in reducing infection. So B.
Okay, everyone agrees? Everyone agrees? Okay, I agree. Okay, I agree. Why? Why option B?
The p-value basically says that the chance, you start off with a hypothesis, which is that this new suture gives you a lower rate of infection. And then the hypothesis is shown to be true to the point that it's less than 5% chance that the study by accident randomly produced this result. So we say that that it's likely that this is a true finding and not a false positive.
Nice, very nice. I'm impressed. Okay, that's correct. So Dr. Rimas said, what is tumor marker for recurrent medullary cancer? You have two choices, two options. You have calcitonin, that's one option, and the other option is CEA, carcinoembryonic antigen. Both of them can be raised. Okay. What about cholangiocarcinoma? If someone has cholangiocarcinoma, what is the tumor marker that can be raised in this funny tumor? Definitely it's not funny, it's a very aggressive tumor. Doesn't joke around. So we've discussed this in the previous sessions, if you remember this. We've discussed about this brief. Yes. Cholangiocarcinoma, tumor marker. I've told you that in the biliary tract, always think about, so there's gallbladder cancer, if there's cholangiocarcinoma, there's pancreatic carcinoma, anything in the hepatobiliary tract you think about? Yes, CA19-9, which is also called Lewis antigen, right? It's a CA stands for carbohydrate antigen. So it's a carbohydrate antigen CA19-9. So in cholangiocarcinoma, it's going to be positive. In pancreatic cancer, it's also positive. In gallbladder cancer, positive. Okay, I have a funny question. In gallbladder cancer, usually, which structure is involved first with that tumor spread? Which structure is involved first? Okay, I'm gonna make a new MCQ, right? It didn't appear before, but just for fun. So my question is, in gallbladder carcinoma, which structure is involved first? I will tell you. Option 1, option A, is coming out segment 3. Option B is coming out segment. Okay, it's coming out segment 8. Option C is coming out segment 5, and option D is common bile duct, and option E is segment 1. Coming out segment 1. Coming out segments, I mean liver segments. Coming out segments, I mean liver segments. So, what do you think? First structure, you have to know the anatomy, right? Coming out segment 1, which is what? Right? The caudate lobe. Right? Segment 1 is the caudate lobe, which is posterosuperior. It's very far away from the gallbladder. Very far away. Right? It's not the first segment. So option E is not correct. What is the liver segment, which is immediately adjacent to the gallbladder? Right? It's segment 5. Segment 5, right? The first two segments that are involved is segment 5 and segment 4. Segment 4 is the quadrate lobe, right? So the answer to this question is segment 5, coming out segment 5, and also segment 4, right? So they cannot put it in the same MCQ. Segment 5 or 4 usually are involved first because they're in the adjacent vicinity of the, what's that, liver, all right? A gallbladder. Is that right? Okay, what is the line? How do we divide into right and left functional hemilivers? First, I have a question. Question number 1 is the liver anatomically is divided into left and right lobes anteriorly by which structure? Yes. Which structure divides the liver anteriorly into left and right lobes? I know you know it. Falciform ligament. Yes, it is the falciform ligament. Okay. This is anatomical, right? Left and right anatomic levers. But we know functionally it's not working like this, right? So what is the boundary that divides the liver into right and left functional levers? Right hemiliver functionally and left hemiliver functionally. I'm about to be impressed by someone, yes? Intake line. No. It has a special name. IVC. You're very close, Dr. Asma. I don't know what do you mean by IVC, but it's very nice. Porta hepatis. Not the porta hepatis. It is not the porta hepatis. Portal vein, not the portal vein. Do you know Cantley's line? Cantley's, our answer. It's called Cantley's. It's not like they can't lie, no. I mean, that's the name of a person.
Hepatic vein? Hepatic vein?
Middle hepatic vein. Excellent. So it is the middle hepatic vein, a line that joins the gallbladder bed to the middle hepatic vein. It's called Cantley's line. Cantley's line. Cantley's line divides the liver into two halves. Functional right, functional left. Each half is divided into further segments, carrying out segments that we know. Of course, you don't have to know the details of how they are divided, but the minimum that you should know about carrying out segments is that the liver is divided functionally to right and left by Cantley's line. You should be aware that segment 1 is the caudate lobe, and segment 4 quadrate lobe. Right? That's the minimum that you should know. Now let's see the next question. Okay, question 11.
Okay, a 50-year-old man is admitted with acute severe pancreatitis. He developed adult respiratory distress syndrome, ARDS. Which of the following effects will occur with prone ventilation? Reduction in function, improved ventilation perfusion ratio. So B is the correct answer. I think improved ventilation perfusion ratio by being prone.
Yeah, so that's correct. So one of the recommended initial mechanical ventilator settings and modes for patients with ARDS. Yes, anyone? Okay. Suppose tidal volume. How much would you put tidal volume? What's the recommended tidal volume in patients with ARDS? In patients with...
Is it like 2 or 3, 2 liters or something?
Typically 6 milliliters per kg body weight. 6 milliliters per kg, but it's very low, right? This is called low tidal volume. Low tidal volume. This ventilation. Low tidal volume is important in these patients. It means that you are not giving a lot of air with every breath, because if you increase the amount of air, there's something which is called volutrauma or volume trauma. The lung will be damaged, and it is associated with higher morbidity and mortality if you use high tidal volumes in patients with ARDS. Now, this is also called permissive hypercapnia. This is also called permissive hypercapnia. It means that, of course, if you have low tidal volume ventilation, carbon dioxide level is going to go up. Is that right? Right? When you use low ventilation, low tidal volume ventilation, naturally, CO2 level will go up, right? Do you agree with me? I think I lost you in the middle, guys. I said that when you use low tidal volume, CO2 will go up. This is called permissive hypercapnia. You can use this as long as pH is not below 7.2. You can use this as long as pH is not less than 7.2. Okay? You should use also physiologic, what's called physiologic beep, right? Beep. It can range like 5 cm H2O, 10 cm H2O. Beep means positive in expiratory pressure. Beep means positive in expiratory pressure. This is the pressure that is maintained at the end of idle breath, at the end of expiration. And this is to prevent alveolar collapse, right? Prevents the alveoli from collapsing. If you maintain pressure in the end, the alveoli will not collapse. The next thing is inverse ratio ventilation. What is inverse ratio ventilation? Yes? What's the meaning of inverse ratio ventilation? Anyone have an idea about this? Inverse ratio ventilation. Okay, normally, under normal situation, which take longer time, inspiration or expiration? Is inspiration normally longer than expiration, or is expiration normally longer than inspiration? What do you think? Of course, normally expiration is longer, right? The expiratory period is naturally longer than inspiration. Inverse ratio ventilation means Then on the mechanical ventilator setting, we set inspiration to be longer than expiration. And finally, prone ventilation. Prone ventilation. Prone ventilation means the patient is nurse prone. It recruits the dorsal regions of the lung and improves the VQ ratio. At least 6 or 8 hours per day, the patient is ventilated while it's prone. So if they have asked you about prone ventilation, it means in the next exam, they can ask about the inverse ratio. They may ask about low tidal volume. They may ask you about the permissive hypercapnia. They may ask you about physiologic beat. Why I'm telling you these things? If they ask this, it means they can ask the other things, right? So, correctly said, Dr. O, that is improved ventilation. Okay, let's take a break for 10 minutes. Okay, 10-minute break. A new link will be sent on the group. Okay, so this meeting will terminate and we will put a new link on the group. Okay, so I will see you in 10 minutes, guys. Thank you. Okay, so we stopped at this point. All right, so anyone have any question about the previous concepts that we've discussed? Are you all clear about what we've discussed so far? Okay, so no questions. Anyone would like to read the questions, please? Just unmute yourself and feel free. Okay, Dr. Amran, go ahead.
On histopathology, lines of Zahn indicate which of the following? The answer is atheroma.
Okay, so what is atheroma? What's the definition of atheroma?
Atheroma is a degeneration of the vessel wall.
Okay, so that's one part of it, that there is some degeneration that happens in the vessel wall. It's basically, nowadays, they define atherosclerosis as a chronic inflammatory disease that is characterized by the deposition of fibrofatty plaques in the intima, with secondary degenerative changes affecting the media. Is that right? That may lead to aneurysmal dilatation, for example. That's why in big vessels like the aorta, there is aneurysm. Lines of Zahn, on the other hand, these are seen with thrombi that are formed in high flow areas, right? High flow regions. So it means that, for example, if someone unfortunately dies, their circulation stops and the blood becomes stagnant in the blood vessels. And there will be clot formation. These clots do not typically have lines of Zahn. That's different. That's the difference between a clot and a thrombus. So thrombus is what? What's the definition of a thrombus, right? Thrombus is just a piece of platelets, fibrin, with red blood cells entrapped, forming in flowing blood. It's important to say that thrombi forms in flowing blood. It's not in stagnant blood. Now, because there is flow, there will be layered deposition of platelets, and then another layer comes, which is formed of fibrin, and then another layer is deposited of cells, right? And then another layer of fibrin. These layered structure that you see, these are lines of Zahn. Okay, so lines of Zahn is seen in thrombi, in a thrombus. Is that right? Okay.
Yes.
Let's see the next question. As you can see, the explanation it says lines of Zahn are characteristic of thrombus formed at sites of rapid arterial blood flow with laminations produced by successive deposition of platelets and fibrin. Fibrin is the pale layer, alternating with red cells. Dark. Those are lines of Zahn. Okay, let's see the next. Okay.
A 68-year-old woman is on warfarin for a metallic valve. She is scheduled to undergo laparoscopic cholecystectomy and she is started on unfractioned heparin. Preoperatively, when should unfractioned heparin is withheld? Okay. Option A 6 hours, option B 12 hours, option C 24 hours, option D 48 hours, option E 72 hours. So I think it's an option 6. Option A, I mean 6 hours.
Yes, so of course you should stop warfarin 5 days. That's also a question in the exam. You should stop 5 days before an elective procedure. Is that right? And then you should do the bridging therapy. The bridging therapy can be done by unfractionated heparin or by low molecular weight heparin. So if you decide to use low molecular weight heparin, when should you stop it before surgery? When should you stop? So we've discussed that unfractionated heparin should be stopped 6 hours. All right. What about low molecular weight heparin? When should that be
12
stopped?
hours.
12 hours to 24 hours.
Yes, so correct. In NICE guidelines, they say you should stop it at least 24 hours. That's according to NICE guidelines, 24 hours, right? Let's see next question.
A 65-year-old man complains of being thirsty and getting up in the middle of the night to pass urine. He weighs 95.5 kg and is 1.65 meter tall, and his blood pressure is 167 by 94 millimeter of mercury. His fasting plasma glucose level is 7.3 millimole, and 2-hour postprandial plasma glucose level is 11.9 millimole per liter. Which of the following is the most likely diagnosis? Option A, diabetes insipidus. Option B, diabetes mellitus. C, impaired fasting glycemia. D, impaired glucose tolerance. E, normoglycemia. So first thing is 7.3. Is option B, diabetes mellitus.
Diabetes mellitus, yeah. So these are the diagnostic criteria. Fasting plasma glucose. Fasting plasma glucose, diabetic when it is 7 or higher. Diabetic when 7 or higher. Oral glucose tolerance test that is following a meal. Diabetic means 11.1 or higher. 11.1 or higher. And HbA1c 6.5% or higher. In an elective surgery, if you have a diabetic patient preoperatively, suppose it's an elective procedure, like for example, repair of an elective abdominal aortic aneurysm, ideally his HbA1c should be what? Should be less than what? If he is to undergo surgery. What's the target HbA1c? Less than? Anyone have an idea? Yes? Can just raise the hand. Less than 69 millimole per mole, which equates to less than 8.5 Is that right? Does anyone have a converter that converts HbA1c from millimole to mole per mole to percent? I think 69 is 8.5%, right? Means less than 69 millimole per mole or less than 8.5. I think so. Okay, let's see the next question. All right.
A 30-year-old man has been bitten in his arm during a fight. Which organism is most likely to be cultured from the wound? Option A, Bartonella. B, Pasturella maltosida. C, Pasturella canis. D, Echinella cordens. E, Staphylococcus bovis. I think it's an... Okay, it's a during fright, so I guess it's a human bite. Then I will choose option D, Echinella cordens.
Yeah, okay. Must have been fighting with a woman, right?
Yes.
Usually they use bites. I've seen men use bites, right? I've been a couple of fights where men use bites, but usually it's the women's side, they use bites and hair pulling and things like that. So there was a funny study where they made a they went to toilets, okay, public toilets, and they took swabs from public toilets. Imagine public toilets that are not sanitary, of course. They took swabs from unclean public toilets, and they took swabs from human mouth, oral cavity. Guess what? Oral cavity has more bacteria than the toilets. Did you know that? Even it's not related to cleanliness, even when they are very clean and they brush their teeth every day, the bacteria in the oral cavity is more than public toilets. The bacteria in the oral cavity of humans is more than that in dogs and cats and rats even. It's a weapon, right? This bacteria in the mouth is a weapon because when you bite someone, there's a high infective load. Human bites are highly contaminating bites. So you would expect that someone that have a human bite would develop wound infection very easily, right? Anyway, so funny story.
Doctor, I have a question.
Yeah.
Okay, when should I choose option B and option C? Like, based on different scenario, when should I choose them?
Okay, so Pasturella species in general are common among animal bite, cat and dog bites. Pasturella species are common in cat or dog bites. They can be present both. The particular subspecies is not that relevant, but you just should know that Pasturella species are more common in dog or cat bite. By the way, I had a question about microbiology. Suppose you have someone with infective endocarditis. I will do the scenario and you will tell me what's the organism. We'll play a game, okay? Suppose someone is an intravenous drug user and he presents with high-grade fevers, rapidly changing murmurs in the chest, and on examination there's a lot of needle marks. He looks wasted and things. What is the organism in case number 1? In this case, what's the suspected organism? Okay, Dr. Hanan raised the hand. Dr. Staff. Dr. Hanan said staff. Dr. Muhammad said staff. Yes, staff. Right. Aureus. This bacteria is in every party, right? This bacteria is in every single party. The most common organism right now in infective endocarditis overall is staph. In the past, it was viridans, streptococci, like Streptococcus sanguis and Streptococcus mites. These are they are alpha hemolytic. They are belonging to the viridans group. They are most common. They are still the most common in subacute infective endocarditis. But now, overall, acute and subacute, the most common organism is Staphylococcus aureus. The common organism in osteomyelitis, Staphylococcus aureus. The commonest organism in, what's that? Arthritis, Staphylococcus aureus. The most common organism in early aortic graft infection, Staphylococcus aureus. The most common organism in surgical site infection, Staphylococcus aureus. So it's in every party, right? It's that guy who appears everywhere, you know? There's a guy, there's that type of person that you see everywhere. Is that right? It's like Staph aureus, that's your friend. Okay, another scenario. Old man with benign prostatic hyperplasia and chronic urinary tract infection presenting with infective endocarditis. What's the organism? What's the organism here? E. coli. It's actually funny enough, it's enterococci. It can be E. coli, but when there is UTI as well as infective endocarditis due to it, the usual organism is enterococci. Okay? So my question, Dr. Azza, my question was, someone with UTI developing infective endocarditis, what's the organism? Right? Enterococci. Someone with cardiac surgery, valve replacement, developed endocarditis in the early postoperative period, what's the organism?
Viridans streptococcus.
What? Come again?
Viridans streptococcus.
No. That's following heart surgery, following cardiac surgery. Postoperatively, the patient developed infective endocarditis. It is Staphylococcus epidermidis. Epidermidis, right? Or whatever it's pronounced, Staphylococcus epidermitis, or whatever. I hate the name, but whatever. You get the idea. Number 4 is someone with colon cancer. Colon cancer presenting with infective endocarditis. What's the organism? Most likely. Bovis, yes, that's it. Streptococcus bovis, which is the old name. Streptococcus bovis. You know, microbiologists, when they name something, they name it very funny name, right? Bovis, epidermiditis, whatever, enterococci, whatever, right? Funny names. Now, when someone comes to change the name of an organism, so Streptococcus bovis is the old name. Now there's a new name. You would expect that they will change it with a better name. Is that right? Something nicer, something easier to pronounce. But guess what? What's the new name? Anyone can guess that? The new name is Streptococcus gallolyticus. You can guess how. So it's, I think the previous microbiologist who named that organism was nicer than the new one. So the new name is Streptococcus gallolyticus. Wow. So that's something just in case you get in the exam. Okay, gallolyticus. Anyway, let's move to the next one. Okay, before that, I have another question. We know, everyone knows infective endocarditis, right? Everyone knows. Dr. Ahmed said in Stickler syndrome. Dr. Ahmed, Stickler syndrome is not related to osteo. Stickler syndrome is a genetic connective tissue disease, right? Related to mutations in collagen genes. The patient present with mid-face hypoplasia, right? You know that syndrome? Mid-face hypoplasia, micronathia, severe myopia, conductive hearing loss, and hypermobile things, hypermobile joints and scoliosis, right? So in Stickler syndrome, it's not related at all to osteomyelitis.
I think he asked about sickler syndrome, sickler patients, osteomyelitis.
Come again, please.
Most common. He asked about sickler patients. Most common organism in osteomyelitis and
Okay, sickle cell disease. Oh, I'm sorry. Okay, sickle cell disease.
Pardon.
Sickle cell. Yeah, sorry about that. Sickle cell disease most commonly is what? Salmonella, right? Salmonella typhi. Is that right? Now in the PubMed, you will see that they say even in the PubMed, they tell you that Staphylococcus aureus is the most common organism overall. In patients with sickle cell disease, they have higher chances of developing Salmonella infection, but in them, still Staph is the most common, but that's not in the exam. Don't answer this in the exam. In the exam, answer Salmonella, okay? Trust me and answer Salmonella. Salmonella is the most common, even if you read somewhere that Staph is more common in sickle cell disease patients. But trust me, answer Salmonella, okay? Now, I have a question. We said that in patients that have infective endocarditis, those patients, do you know any other form of endocarditis besides infection? Do you know any other form of endocarditis? Yeah. Excellent. Dr. Reem said autoimmune. That's correct. In SLE, what's that called? In systemic patients with systemic lupus erythematosus, they develop something called Lippmann-Sachs, right? Lippmann-Sachs endocarditis. That's correct. Lippmann-Sachs endocarditis. It's not infective. Okay. Any other situation besides SLE? Have you heard about Marantic?
Oh.
Marantic endocarditis. Marantic endocarditis is associated with hypercoagulable conditions, especially malignancy, right? Especially in malignancy. It's non-infective vegetation. Okay. And there is rheumatic endocarditis. Rheumatic endocarditis. So why I'm saying this? I'm saying this to get to the question. Okay, I'm saying this to get to this question. In rheumatic carditis, okay, in rheumatic carditis, if you take biopsy, what is the pathognomonic lesion? Pathognomonic lesion that you see, if you see it, you say, oh, this poor man must have been having rheumatic carditis. I'm about to be impressed by someone, yes? Mitral regurgitation is not pathognomonic. Mitral regurgitation can occur in wide array of conditions, right? It's not pathognomonic to rheumatic heart disease. I want something in the microscope, under the microscope, biopsy, histology. You see it, you say, oh my God, this guy, poor guy, must have been having rheumatic carditis. I know you know it. I know you've heard about it. It's common. But yeah. Ashov, nodule. Ashov, M protein is the protein, the streptococcal protein. Allah. M protein is the streptococcal protein, right? You know that when patients have sore throat, strep group beta hemolytica, Lancefield group A, streptococci, they have M protein. M protein has similarity to our own antigens. M protein have similarity to our own antigens. So there's cross-reactivity when antibodies are produced. So it is Aschoff nodule. Aschoff nodule. What is Aschoff nodule? Aschoff nodule is just a collection of denaturated collagen fibers, macrophages, and lymphocytes. And the macrophages inside of the Aschoff nodule is very characteristic type of macrophage. I'm about to be impressed by someone. Please tell me, what's the name of that macrophage in Aschoff nodule? Please tell me that. A Nitschkoff cell. Excellent. So after all, microbiologists are not that bad, right? With the naming. Pathologists are worse. That's called a Nitschkoff. I don't know how to write this. Nitschkoff. I think like that. I'm not sure. A Nitschkoff or caterpillar, better term, caterpillar cell. Yes. A Nitschkoff cells. A Nitschkoff cells. Aschoff nodule contain a Nitschkoff cell. This is pathognomonic. That can be a question in the exam. Okay, now it's prayer time. Let's take a break, okay? For 10 minutes. Another break, I'm sorry. So, but today is Friday. I have all dates. I can stay longer with you. So let's take a break, 10 minutes. And again, a new link will be posted on the group. So see you then, okay? See you in 10 minutes, guys. Thank you.